there's probably no bigger area of options than in the treatment of cartilage injuries in the knee. And this is the articular cartilage, the cartilage surface of the knee. And I guess anytime you have a plethora of options that you can read about, that means you probably don't have one that's perfect. None of them are ideal. So when we're talking about cartilage surface injuries, the younger the patient, the more the goal is to restore normal cartilage. The older the patient, that might be less of a goal. It might just be remove anything unstable that's moving around or flipping and catching and leading to mechanical type symptoms, and just smooth it up and realize that you can't really fight nature, so to speak. We all kind of grow up and get some arthritis or degenerative changes as we age. And there comes a certain point where you can't fend that off. So I would say that under 40, we're a lot more aggressive with treating cartilage injuries to try to restore halfway decent cartilage, and at least keep it from breaking down further. Over age 40, particularly over age 50 or 55, because partial knee replacements and total knee replacements are such good options in that age group, we generally aren't very heroic trying to restore a normal cartilage surface. And I think that the patients need to realize that sometimes a minimal approach can be okay. If you have a little pothole in your cartilage that's catching and popping because of a trapdoor effect, well, maybe if you just smooth it, your knee might work great. You might be fine and feel like you're normal for a long, long time. Any attempt to truly restore cartilage usually involves bigger surgery and a whole lot more protection. So you have to weigh these things in the balance. Is it really worth that? And how much gain am I really going to get? And one of the problems with some of the surgical options for these is, I kind of jokingly say they're like the east-west punt return operation. It's a lot of effort, but you didn't really push the ball down the field very much. And that can be really frustrating to a patient to sign up for something that's big surgery and a lot of rehab, and yet ultimately in the end it doesn't help them that much. And we see these patients in the office all the time, and there's a high level of frustration with that. If you've gone through a lot of expense, a lot of rehab, time off work, pain of surgery and this kind of thing, and you're really not all that much better, it's frustrating. So I think with cartilage surgery for the articular cartilage, it's really good to take dead aim, have a good plan, know what the goals are, match the goals with the patient, and then you match the procedure, for the patient and the goals. And sometimes it's big surgery, sometimes big problem can mean you need big surgery and protect it. But if you're going to do the bigger surgery, I would choose one of the options that really, truly does restore normal cartilage. If you have a big, full-thickness chondral defect or cartilage defect in the knee, choose one of the options that's giving you really good, normal cartilage. And often that's a transplant of a dowel, of a circular graft of live bone and cartilage that really replaces the cartilage surface in the knee.